Thank you so much, Allison. That was really fantastic. And I think your last question is probably the most provocative,
Yeah.
and maybe to kind of pose it to both you and Oliver is with all of these strategies, how do you prioritize, um, which combination?
Yeah, it's difficult, right? And we always talk about it. What can we make the most difference with early? And I think for us, we know that, both CD3 bispecs and CAR T have really the potential to provide huge numbers of T cells that can respond to a tumor. So we were excited about that. So then the question is, how do we enhance those responses? And we've went with the kind of next step first, and the obvious step, which was how do you increase those responses further. But I think Oliver made a good point too, that the innate immune response is hugely important in ovarian. So should we be bringing in blockers of MDSCs or enhancing activation of macrophages and dendritic cells with our CD3 bispecifics, and what other combinations would make sense? Even anti-angiogenics with the CD3 bispecifics, given the evidence we have with some kind of increase in inflammation there.
And that probably leads into a couple. There's a number of questions flying through the chat right now, and they're somewhat related about since ovarian cancers are mostly cold tumors without sufficient T effector T cell infiltration, will the CD3 bispecifics work in this setting? And then how do you select patients using CD8 staining in biopsy samples?
Yeah, so we're definitely examining that at the moment in our trial. We're getting, pre and post biopsies to examine the both the MUC16 expression as well as the T cells. There's definitely T cells present on ovarian. It's definitely not the most T cells compared to some other indications. But the beauty of things like CD3 bispecifics is you can actually increase the number of T cell infiltrating tumor infiltrating T cells by using bispecifics. So in our preclinical models, we showed in several different models that you increase the number of T cells that are present in the tumor after treating with CD3 bispecific. At the moment, we're not sure if that's merely due to proliferation of the T cells that are already in the tumor or whether it brings in new T cells. But we also induce inflammation. So we see a lot of, interferon gamma, TNF alpha, IL-2 come up in the tumors in response to this T cell activation. So as much as there may be lower numbers to start with, the fact that we can make these T cells proliferate and then also induce inflammation likely kind of overcome some of that and really gets the inflammatory response going. And
And actually, maybe a follow-on to that is a subsequent question about whether or not there's been any attempt with the combination CD3 MUC16 and the CD28 MUC16 combinations in the in vivo model. Have you tried to dissect the effect of a co-stim versus the CD8 versus the CD28 MUC16, just trying to tighten that immunologic synapse?
yeah.
And is that effect clearly dependent on CD28 signaling?
Yeah, we have a great team of people that have showed that, that the CD28 bispec really goes into that synapse as well and kind of enhance the synapse and temporarily increase it. We haven't done too much more than that. I think one of the ideas we've been playing with as well is which co-stim is the best one. So for example, CD28 is on the naive T cells and is important for activating the initial T cells, but 4-1BB is up on these tumor infiltrating T cells and can really help expand. So we have some preliminary work showing that actually the 4-1BB combination was phenomenal. With a different CD3 bispecific than the one I'm discussing today. It really expanded the T cells even further and increased the activation of the T cells for longer after treatment. And we were able actually to clear much larger tumors, even 350 millimeter cube tumors with a combination with 4-1BB and CD3 bispecific. So one area we're interested in is more, which co-stim and also when can you treat with it? Yeah.
And actually, that's a question that maybe for Dr. Dorigo as well is sort of, can you speak a little bit to the timing of, what would be sort of the optimal timing to implement some of these strategies, in the front, in sort of in a minimal disease kind of setting versus where you, Allison, showed, even in sort of large established formed tumors, you're actually able to induce regression. So maybe for Oliver, for your approach, any thoughts on that?
Yeah, I mean, as I told as well, that when the tumors are smaller, they're obviously much easier to treat. And I'm sure that'll be true in the clinic as well when we get into those earlier patients, that even maybe a CAR-T alone or a CD3 bispec alone may even be enough. And when you're getting into those late stage patients, you're going to need the combinations. I think a lot of it, somewhat unfortunately, may have to be kind of worked out in the clinic though, because a lot of these decisions will be based on toxicity more than efficacy, or at least as importantly on toxicity. So with CD3 bispecifics, you get a very, very large initial blast of cytokines that are released into the serum. But then in subsequent doses, though, that cytokine release is much lower. So would we want to combine, for example, 4-1BB and CD3 in the first dose? Or would we give CD3 bispecific first, maybe even do a step dosing, get over any CRS, and then come in with something like 4-1BB? And I think that thinking might help choose what's the best combination as well, right? So 4-1BB is a kind of exciting one just because it gets increased upon T cell activation. So the CD3 bispec further increases 4-1BB. So it also makes sense to maybe stagger that dosing. So I think a lot of it is unfortunately going to be worked out in the clinic of when we can dose to get the best efficacy while mitigating the toxicity.
Oliver, some thoughts about that as well as the targets that you've proposed?
Yeah, no, this is fascinating. I think development of a hopefully beneficial strategy, Allison. I was wondering, this approach, you're right, probably works best in patients with minimal disease. In general, immunotherapy works better in patients that have small sized tumors. The bigger the tumors get, and that's our clinical experience, the less it works. And we actually have done this in ovarian cancer. We used to do interleukin-2 interperitoneal chemotherapy. I think Bob Edwards was really pioneering these studies, and he has shown complete responses in platinum-resistant patients and very long-lasting ones. It's just that interleukin-2, as a generally T-cell stimulating cytokine, is very toxic and it's not approved and it's very expensive. So for all these reasons, we don't use it. But as a proof of principle, it works as a T-cell stimulator. And actually, Jonathan is an expert on interleukin-2. But that being said, I was wondering whether in combination with drugs that increase T-cell infiltration that we already have on the shelf, meaning bevacizumab, for example, that is very well known by targeting VEGF to increase T-cell infiltration. We have it as a maintenance strategy, right, in ovarian cancer patients after first-line and recurrent treatment. So, what do you think, Allison, about combining in a maintenance setting, first-line, your anti-CD3 approach with bevacizumab, or maybe doing this in patients that, as we said before, have this great unmet need, and which is the homologous recombination proficient population? I think this would be an interesting approach.
No, I agree completely. And it's always, obviously important to look at what's already approved and what we can more easily add to. So there's both preclinical and clinical data suggesting, at least with PD-1, you can combine with these anti-angiogenics and get increased responses. So it may well be that we can increase CD3 bispecific responses too. I think it's definitely somewhere we should go, this maintenance setting with treatment with anti-angiogenics, and see if we can get a better response there.
Right, and if you spin this further, right, PARP inhibition also increases the ability of the tumor environment to elicit anti-tumor responses, because it does increase cytosolic DNA, and then you stimulate the STING pathway. We've shown this in ovarian cancer, that combination of pembrolizumab and niraparib, or PARP inhibition plus immune checkpoint inhibition, can have efficacy. 18% of patients with refractory and platinum-resistant ovarian cancer respond to that.
Yeah.
And I don't know whether you use it, Yvonne. I do use it in my patients as a combination strategy. And maybe with your approach, even a PARP inhibitor might be at least additive.
Yeah, I feel like there's a little bit less data on the PARP inhibitor and how much inflammation that can really induce. I think there's a bit more solid data for the anti-angiogenics, but yeah, there's definitely kind of intriguing data. And yeah, the best data is the clinic, right? You read out combinations with, say, checkpoint. If you're seeing enhanced responses, then it does suggest it can increase immune responses. And yeah, I think that's kind of also the key to getting into the earlier patients as well, right? We need to be able to show that in the maintenance setting, given that they're getting PARP inhibitors and anti-angiogenics, we need to be able to show that our bispecifics can work in concert with those drugs, and definitely, not decrease the effects and hopefully enhance responses there. And I think that is the key to being able to move from those late stage patients into the earlier stage.
Yeah, and I think that the notion of the PARP inhibitors plus the checkpoint inhibitor, I think the data is not reliably stable enough to sort of advocate that that combination. There are, for people to be aware of, there are 4 frontline ovarian cancer trials that are studying that combination of checkpoint plus PARP inhibitors. Many due to read out, at imminent in the next year or so. So that's something to kind of be on the lookout for. Maybe in the last 5 minutes, some questions for Dr. Dorigo that had come through since we didn't have time after your talk right away. Someone had asked whether or not, if the kind of 2 questions is sort of, among all of the different signals, the CD24, 27, et cetera, 47, et cetera, how do you prioritize that? And also the concern of, if you block one, how does that impact the other signals? And what's the current thinking now in terms of sequentially blocking them, or does blocking one before the other make more sense, especially in light of potential toxicities and tolerability?
Yeah, that's a great question. Thank you for asking these questions. I mean, if you roll this question up from the back end, toxicities, the anti-CD47 approach had to be tightened, so to speak, because we start seeing anemia in these patients. CD47 is expressed on early forms of erythrocytes and or older forms of erythrocytes, that is, and they had to be deleted before you could actually escalate it to a higher dose. We saw also initially some patients that have very strong activation of macrophages, and we know this very well from, particularly CAR T cells. We get this macrophage activation syndrome, which is at times difficult to deal with, but that was mitigated by a dose escalation scheme that these patients were treated with. So, I think we can get around the toxicity. I think it's a great question to ask whether a sequential approach will work or combination approach. As I said, I honestly don't have data on this, so I won't make any further comments. I think this is all the things should be studied going forward.
So, and in the next, maybe another question is anyone looking into the innate lymphoid cells, or ILCs, to target ovarian cancer?
That's a great question. And there's various innate lymphoid cells. The data that I'm aware of actually pertains to neutrophils, which are part of the innate lymphoid cells. And those neutrophils, somewhat similar to macrophages, can actually influence anti-tumor responses. There are these neutrophil nets that contain neutrophil DNA and are important in anti-tumor responses. And I think that's been definitely a target of investigation most recently. Beyond this, I think this is a very interesting cell population to target, and hopefully we see some more focused data on this cell population.
And then maybe another question for the both of you, and maybe you can start, Oliver. Given the sort of the interest in sort of the rationale of using these approaches in sort of a smaller disease volume kind of a setting, do you envision being able to sort of leverage this kind of therapeutic approach in either a very early line setting, and or a prevention kind of a setting, not simply secondary prevention, but even primary prevention? Is this a immunologic milieu that can be titrated?
Yeah, Alison, you want to comment or?
Let's see. I think, yeah, I think the key for us is we're really just focusing on getting into the earlier stages of patients, not in prevention, etc. So getting beyond the kind of late stage and into the stage 1 or 2 soon after, really at the maintenance stage, I think would be the easiest way for us to get into. And as Oliver mentioned, that all depends on looking at combinations with the standard of care chemotherapy, as well as PARP inhibitors, as well as anti-angiogenics, to make sure that we can potentially continue those standard of cares with adding on to our bispecific.
Yeah, so my thoughts are that any new strategy traditionally has been tried in patients that had no other treatment options. They're out of standard of care option. I think that Hong alluded to this, should we move even novel approaches, first time in humans, into the early treatments. That's a difficult one to justify, since you don't know about toxicities, you don't know about efficacy. You want to see some efficacy in patients that don't necessarily have so many other treatment choices in ovarian cancer. From these trials, I think we have a mandate almost to understand translational endpoints and hopefully identify predictors of response. Alison, for example, in your study, is the efficacy of this bispecific antibody dependent on the presence of T cells, the amount of CN25 expressed on these cancer cells? I think those are translation endpoints that will inform the next trials. And then these next trials can be focused on certain subgroups that were identified in the first phase of the development of these drugs, making this a more precision-directed, precision medicine-directed approach. And I think that we are looking for this. I mean, we have done, I think, a fabulous job with development of PARP inhibition. We know that the BRCA1/2 mutation carriers, for those patients, it's standard of care to give them PARP inhibitors after first-line treatment. The HRD high population, those patients also benefit from PARP inhibition, but who really benefits from the approaches Alison proposed or that Jose talked about today? We simply need to do that science.
Yeah.
Yeah.
I agree, especially with our CD28 and PD1 co-stim there, we need to understand, is that also working better in the BRCA patients or the HRD patients all tying together, because they may have more neoantigens. And we need to make sure that when we're taking biopsies from the patient, we're asking good questions, and then we're sharing that information to really understand how can we then move forward. Where is it working and how do we boost those responses? But also, more importantly, where is it not working, and therefore, what else do we need to do for those patients?
Yeah. No, I completely agree. I think there's plenty of questions. There's so much that's there's so much that's unknown at this point. With the novel therapies, and especially, the timeline, the length of time to really understand the length of time that currently exists with following traditional clinical endpoints. We really need it's really critical, I think, having earlier endpoint to kind of gain an insight as to what is your experimental agent doing, and how well does that actually correlate to your traditional clinical endpoints that may be several months, if not a couple of years out.
Yeah, and identifying those markers is one of the biggest challenges, right? And all we can really do is take two approaches: use flow cytometry and IHC on known markers that may help us really understand. And it's the obvious things like our T cells there, what's the proportion of Tregs versus CD8 cells, etc. But then also make sure we're doing, RNA sequencing to really get that broad approach as well, to see what kind of undirected kind of things may come out and help us really pivot and change what we're doing.
Yeah. So I think with that, we're exactly we're back on time. It was dicey there. I think at this point, I'd like to really just thank Oliver and Alison for to really amazing talks, and maybe hand it over to Jonathan for sort of next remarks.
Yeah, thanks, Yvonne. And let's see, how do I share my screen? Well, I'm trying to figure this out. I mean, just again, a huge thank you to everyone that has participated in today's event, both those in the audience generating very exciting discussion, and of course, our speakers and panelists who have deep expertise in ovarian cancer and have showed us we've come a long way since the early 90s or early 80s, but we still have a long way to go, especially for the treatment of ovarian cancer and the use of immunotherapy in ovarian cancer, and just understanding basic biology of ovarian cancer. So with that, I just want to wrap up by providing a few additional resources to those that would like them. That we'll make these slides available after the meeting, and the meeting was also recorded, so we'll also make the meeting recording available to everybody. But just so you all have it, if anyone has any additional information they would like to get on the Antibody Society or becoming a member, the Antibody Society hosts a number of events, webinars, symposiums, educational talks that go well beyond ovarian cancer. And so their website is listed here. And of course, the Ovarian Cancer Research Alliance website is listed here. And then a lot of statistics and just general information on ovarian cancer detection methods or symptom signs, things like that are available on the OSIRI's website. And again, as Jake mentioned, we are currently in the midst of Ovarian Cancer Awareness Month. It is September, that is Ovarian Cancer Awareness Month. And so the OSIRI has kicked off this coast-to-coast fundraising effort. And so for those of you that are interested in contributing to those efforts, you can do so via the link below or the QR code. And then one other thing I just wanted to bring attention to is an event that's been years in the making, originally scheduled for April 7th, 2020. And as many of you know, March 14th or 15th, 2020 is when we shut down due to COVID. This is a gala, we'll call it a gala in this case, because we're doing our fundraising efforts now at the end of the year. So, this will be more of a celebration of bringing people together to benefit and support ovarian cancer on the top floor of the Salesforce Tower. So this has now been reconfirmed, I guess, pending any more COVID-related cancellations for March 24th, 2022. And for those of you that are interested, again, the information is here on the slides, and you can use the QR code. If you haven't been to the top of the Salesforce Tower, whether you live in San Francisco or not, there's some pictures below. It's absolutely stunning. And we had and have a great lineup for the event. A lot of food, entertainment, auctions. So yeah, if you are around, feel free to join us. We'd love to have you. And then with that, I'll just say my thank you for all of you attending again and helping spread knowledge and awareness around ovarian cancer. I mean, I think this is an area or a cancer that particularly sort of lacks a lot of knowledge around it. And there are many misconceptions, as have been described, around symptoms and signs and treatments. And so thank you all for attending. Thanks to you again, Janice, Pam, for helping organize the seminar, Oliver, Yvonne, Allison, Jose, and Jake had to leave, but for your excellent talks and discussions and taking your time out of your very busy schedules to be here today and help support the community. And with that, I will say thank you and turn it over to Janice.
Thank you very much, Jonathan. And I really can just second some of his points. On behalf of the Antibody Society as the official representative here, I want to thank the Ovarian Cancer Research Alliance for partnering with us on this event And we're so appreciative to the speakers for sharing your time as well as your expertise. I think and hope everyone learned a lot from it. I certainly did. I definitely want to thank Jonathan for putting together this really fantastic program. And also, of course, to Pam and Boyan there for saving the day behind the scenes. I'm sure many times that we were not aware that you're having to put in effort to keep all the cats herded, so to speak. And also, of course, for this amazing implementation of Jonathan's vision for this event. Finally, I, of course, want to thank all the attendees for taking the time to be here with us today. I certainly hope you added to your knowledge and awareness of ovarian cancer, and you'll take that out and spread that amongst the world. With that, I officially conclude the symposium, unless Pam has something else to add. If not, then I hope you have a great rest of your day. Thank you.
I will give one more shout out to Hong, who I forgot to acknowledge. I realize now that I can see everyone's faces, I forgot to acknowledge Hong for being here and participating as a panelist, and of course, again, also providing your time while traveling international. So thank you.
And I second that too.
Great. Thank you, everyone.
All right. Yeah, thank you.
Everyone.
Thanks.